Hello and welcome to the Exam 2 study guide. I'm going to go through a case study about Alzheimer's disease and dementia and talk about all these considerations. This is taken from the Clinical Reasoning Cases in Nursing book, case study 121. And then at the end, I will go through some practice exam questions to help get you in the mindset of studying for the exam and what to look for. So let's get started. First off, here's the scenario. You are the nurse working in an outpatient clinic. This afternoon, a woman brings in her father, KB, who is 74 years old. The daughter reports that over the past year, she has noticed her father has progressive problems with his mental capacity. These changes have developed gradually but seem to be getting worse. At times, he is alert, and at other times, he seems disoriented, depressed, and tearful. He's forgetting things and doing things out of the ordinary, such as placing milk in the cupboard and sugar in the refrigerator. KB reports that he has been having memory problems for the past year and at times has difficulty remembering the names of family members and friends. His neighbor found KB down the street 2 days ago and he did not know where he was. This morning he thought it was nighttime and wondering what his daughter was doing at his house. He could not pour his own coffee and he seems to be getting more agitated. A review of his history is significant for hypercholesterolemia and coronary artery disease. So when we're looking through this case study, first we should highlight some areas of concern in this scenario. So things that we should notice would be, over the past year. So this is a gradual onset, seems to be getting worse. So it's progressing and getting worse. Other things that we are going to notice is that he has difficulty remembering the names of family members and friends. This should stick out to us as a problem, such as a memory problem that has stuck out. And here he is this morning that he was disoriented. This morning he thought it was nighttime and his neighbor found him down to the street and he didn't know where he was. So these are big red flags on what's happening with memory that we're seeing. It's getting worse. He is losing functionality of simple day-to-day tasks like pouring his own coffee, getting more agitated. And where is my tearful and the different behavioral things? Here he is, disoriented, depressed, and tearful is what the daughter is noting. So now we're also seeing emotional and personality changes. And then my last area of concern here would be hypercholesterolemia and coronary artery disease. And so those are going to put us at increased risk for cardiovascular disease and vascular type dementia. So first thing when we're reading through a case study, we want to pinpoint all of those concerns that we have. So we want to talk about normal cognitive changes of aging. So firstly, we identified that KB is having some significant cognitive changes over the past year. To recognize this, we need to first recognize what would be normal cognitive changes in aging. So here's a list that will help to differentiate between mild cognitive impairments and mild dementia. Mild cognitive impairment and dementia will have noticeably impaired short-term memory. The individual will have limited or no awareness of memory limitations. Mental status will start to decline and ability to perform those instrumental activities of daily living will be impaired for mild cognitive impairment and dementia. One gray area in our mild cognitive impairment is social skills and ADLs, because in mild cognitive impairment, the social skills and the ADLs are usually not affected, whereas in dementia, we will see changes in social skills, so kind of inability to hold a conversation, inability to remember and follow the conversation, as well as declines in the ability to care for themselves. Some other normal cognitive functional changes in aging include declines in the ability for calculation, word fluency. So older adults are going to have more tip of the tongue experiences like, oh, what word am I looking for? Inductive reasoning will decline as we all age, and verbal comprehension. Also, older adults are more prone to cognitive impairment related to mental health issues such as depression, anxiety, as well as diminished sensory input like hearing and vision changes. poor health, and even the attitude of society in whole, those ageist attitudes about what healthy and normal aging looks like, will influence how a person portrays themselves. So physiological changes which influence cognition, there can be sensory impairments or neuronal death that are actual physiological changes of aging that will affect our cognition overall. So vision and hearing can affect cognitive functioning because they interfere with one's ability to receive information. So hearing loss is associated with cognitive impairments, and if hearing and vision loss occurs, our cognitive abilities are greatly reduced. Secondly, on neuronal death, the structural and functional changes of the brain correlate with age-related cognitive changes, which include those alterations in neuronal structure with neuronal death, loss of synapses, and dysfunction of neuronal networks. The most important changes in cognition with normal aging are declines in performance on cognitive tasks that require one to quickly process or transform information to make a decision, including measures of speed processing, working memory, and executive cognitive function. So is it delirium or is it dementia? And so looking at KB, do we think it's still, he's showing us more signs of delirium or more signs of dementia? So here's a slide kind of delineating some big differences between delirium and dementia. And those two top bullets are really the first big changes. So in delirium, it's going to be sudden. So it's an acute change in cognition, where dementia is more of a gradual decline in cognitive functionality. But manifesting, they can look very, very similar. In delirium, that sudden onset of symptoms is going to usually be is usually also a part of it is the inattentiveness and the distraction. So in delirium, we can have hyperactive, or we can have hypoactive, or we can have a combination of both. So hyperactive manifestations or behaviors is that restlessness, wandering, emotional lability, where hypoactive is very lethargic, delayed speech, unresponsiveness. And where in dementia, we have progressive functional impairment, and we have behavioral and psychological symptoms, BPSD, which we go in great detail in the book about what those are and how to deal with those. One assessment tool that we can use to kind of distinguish is it delirium or a different cause of confusion is our CAM assessment tool. It's a confusion assessment method. It's the most widely used tool to detect delirium in the acute care settings and in long-term care facilities. So with delirium, we have to have the presence of 1, an acute onset, and 2, inattention, as well as possibly 3, disorganized thinking, and 4, altered level of consciousness. So again, it's very acute in delirium, where dementia is progressive, gradual. So based on the symptoms described by KB and his daughter, he's most likely experiencing dementia because his changes have been looked at for over a year. They've been occurring for over a year, and he's also having personality and emotional lability, such as his newfound tearfulness, agitation, and at times depression. She also describes him at times being alert and other times being disoriented. And lastly, he's showing us more functional impairments, such as unable to pour himself some coffee. So here's a list of the types of dementia and a very brief overview of what they look like. So vascular dementia is abrupt in onset usually, and they're accompanied by a large history of vascular risks like uncontrolled hypertension, stroke, atherosclerosis. Alzheimer's disease is more insidious on the onset, has a preclinical era, and then you can see the clinical manifestations, and it's very slowly progressive to severe Alzheimer's, usually within 5 to 10 years of diagnosis. The third one is a Lewy body dementia, which is also insidious in onset, and it has more musculoskeletal impairments similar to Parkinsonism. And lastly, we have frontotemporal dementia, which usually occurs more in the younger group of people between 45 and 64 years old, associated with a family history, and frontotemporal dementia is also gradual in its onset. Assessment scales in dementia, there are numerous that we can use, but how do we use them, and when would we use them? And so the mini mental exam takes just a few minutes, and it is done usually it can be done quickly in long-term care, but is also used in acute care to see a person's judgment and insight. And on that mini mental, we ask them just, 2 questions. So we ask them to remember this word: car, red, plate. And then you talk for them for a while, and then you say, hey, do you remember those 3 words that I told you to remember? And then we have them draw a clock with the 12 numbers on it and a time that we give them, and we see how they can put that together. And that gives us a quick idea of where they're at with their judgment and ability for decision making and memory. MOCA is also commonly used, which is the Montreal Cognitive Assessment Tool. And then lastly, the healthcare professional can determine the degree of cognitive impairment using the GDS, or the FAST, which really shows more of our effects on functioning and our ability to function with memory loss. So many assessment scales that we can use to assess cognitive function in our older adults. Here's more about KB. His vital signs are normal, within normal limits. He's pleasant with coherent speech, although he does not speak unless asked specific questions. General and neurological findings are normal. On cognitive testing, he scores a 24 out of 30 on the mini mental state exam, missing 4 points on orientation, 1 point on recall, and 1 point on intersecting pentagon drawing. Further detailed testing confirmed deficits in orientation, memory, and visual spatial skills. He also had difficulty with the clock drawing test. So we're seeing changes in these testings. So out of 30, 24 out of 30 isn't bad. Oh, I think I wanted yellow here. But he is scoring, lower. It should be 30 out of 30. And we're seeing other testing that they're doing, showing visual spatial skills, memory, orientation, as well as the clock drawing. So they've done several testings here to see his cognitive ability, and he's showing some decline. So diagnostic testing and dementia. A lot of the diagnostic testing that we're going to do when someone arrives with confusion, disorientation, impaired judgment, we have to do many tests, mostly to rule out an underlying cause. The neuroimaging that we have nowadays are so much improved, even in the last 20 years. But a lot of those, like the PET scan that you see on the right side of the screen here, those are really limited to research facilities, and we don't have easy access to those in kind of the more streamlined healthcare settings. So firstly, to rule out underlying causes, you can see a list of tests there. But a physical exam to measure blood pressure and other vitals is going to be necessary to see is it TIA or stroke, as well as different laboratory tests of blood and other fluids to check for chemicals, hormones, vitamins, to rule out those other signs and symptoms. So a toxicology screen to rule out heavy metal, right? That can cause a lot of encephalopathy, or just drug use, right? Our CMP complete MET panel, we can see, is it acidosis, alkalosis? Do we have electrolyte imbalances like hypo or hypernatremia that's causing this lethargy or confusion? Complete blood count with differential can tell us about infection, acute on chronic. If we have severely low B12 levels, we can see cognitive dysfunction. Liver function tests will let us know about ammonia levels, and ammonia can be very toxic to our brain tissues, and so that would help give us an indication of if it's liver disease and hepatic encephalopathy. Like we talked about before, when vision and hearing loss are apparent, cognitive decline ensues. And then a UA to determine UTI, because in our older individuals, when a patient gets a UTI in advanced age, one of the first symptoms we see is confusion. So the neuroimaging specific or to help us then after we've ruled out any other underlying or organic causes is CT scans, MRI, and possible EEG. So CT scans show brain atrophy, strokes, ischemia. They can show changes to blood vessels and other problems such as subdural hematomas. MRIs pretty much detect the same thing as our CT scans, but they're better. They have better sensitivity to see the brain atrophy and damage from small strokes or subtle ischemia, such as those changes in vascular dementia. And lastly, EEGs are ordered in people with suspected seizure activity. The electrical activity on EEG can indicate cognitive dysfunction in part or all of the brain, and many patients with moderately severe to severe dementia of any sort have abnormal EEGs. An EEG also may be used to detect seizures, like I said, which occur in about 10% of Alzheimer's patients, as well as many other disorders. After reviewing KB's history and diagnostic test results, KB is diagnosed with Alzheimer's disease. The provider calls a family conference to discuss the implications with KB and his family. Fortunately, KB has a supportive daughter and 3 sons who live nearby who can function as caregivers. KB's son asks, how did he get Alzheimer's disease? We don't know anyone else who has it. So we want to think about how do we respond to this? What changes are happening? What is Alzheimer's disease? And how do we explain it to a family? So as a nurse, we can understand the pathophysiology, the clinical manifestations, and how to treat a patient with AD. However, we want to make sure that we are communicating clearly in an easy language that what AD is and how that entire family and patient will be affected. For nursing reasons, we want to know about those neuroanatomic changes, and those changes for our sake of nursing are the loss of neuronal functioning, atrophy of large cortical neurons, loss of synaptic connections between our neurons, an accumulation of neuritic plaques and neurofibrillary tangles. And specific to AD, we have abnormal deposits of beta amyloid protein and abnormal clusters of our tau proteins. In AD, the hallmark neuroanatomic change is a gradual progression of brain atrophy that progresses from the preclinical stages to severe stages of dementia. So going back to the family, when a family member has Alzheimer's disease, it really does affect everyone in the family, including children and grandchildren. So it's important to talk to the family about what is happening and what to expect. So we want to let them know that, Alzheimer's disease accounts for most cases of dementia. So 60 to 80% of the cases of dementia are attributed to Alzheimer's disease. And that's why there's so much research and programs and money put into Alzheimer's disease. Factors that are going to increase the risk are family history, which they didn't say that they did have, but any of the risks for CV disease are going to increase the risk for Alzheimer's. So smoking, obesity, diabetes, hypertension, hyperlipidemia, and looking back at KB's history, what he had was that hyperlipidemia, and he had coronary artery disease, which I'm just circling hypertension because that is a CV risk factor as well, like all of them. But traumatic brain injury and increased age is going to increase the risk of developing Alzheimer's disease. We want to let family know that Alzheimer's disease manifests as memory loss that gradually progresses, and that it's going to interfere with judgment, decision making, memory, and difficulty completing familiar tasks. So we also want to reassure patients and their families how to communicate with a patient, especially as the disease progresses. And so some of these techniques that we can use on communicating with a patient is to be calm and quiet. So don't use a loud voice or talk to the person as if they were a child. We want to respect that person's individuality as well as their personal space and not get too close. Another technique is to encourage that two-way conversation for as long as possible. We want to remind caregivers to be patient when someone has trouble finding those right words or trouble putting their feelings into words. So we can help them maybe find a word, but not speak for them. And also try not to take it personally if that person does not remember you. And that's really hard, especially more for children and spouses of patients who have Alzheimer's. The patient is going to have maybe some emotional lability. So when they're unkind or angry, they're acting out of confusion and an inability to communicate. And we try to encourage them not to take it personally. We want to help family and friends realize that the person can still do, what can they still do and how much can they still understand. So encourage them that they're still that person they love and care for. It's just they're having a lot of difficulty with communication at this point. We can give suggestions on how to start talking with a person. For example, you might come up to the patient with Alzheimer's and say, hello, George, I'm Katie. We used to work together, to give them a quick reminder to maintain that dignity. Help the family members avoid correcting the person, or friends. Help tell them not to correct them if they make a mistake or if they forget something. Instead, ask them to respond to those feelings that the person is trying to portray or get across. And lastly, having fun activities and doing fun activities with the patient with Alzheimer's, such as the reunions, visiting old friends, video calls that we're all so familiar with COVID, viewing a photo album together. Those are all things that we can send to the person to help with memory and to make them feel connected. Medications for Alzheimer's are going to, there's several of them, but at the same time, there's not many. So medications for Alzheimer's do reduce symptoms, and they can slow the rate of decline in some patients with dementia. But what they do not do, and what we need to let the patient and caregivers know, is they do not cure the dementia. They just can modify and slow the progression, but they don't actually fix the underlying pathology. So there are 4 medications there. The first 3 are cholinesterase inhibitors, and these are going to block the action of acetylcholinesterase. And what this enzyme does is it breaks down acetylcholine at the neuronal synapses. So if it normally it will break that down, so a cholinesterase inhibitor will allow for more acetylcholine in that synapse, and so it will have quicker transmission and cell-to-cell messaging. So those top 3 are the cholinesterase inhibitors, and the bottom one, Namenda, isn't a cholinesterase inhibitor, but it works by blocking the toxicity associated with excess release of glutamate. And the top 3 are for mild dementia, where Namenda is more for moderate to severe Alzheimer's disease. So the usual approach for pharmacological management is to start a cholinesterase inhibitor before or during those mild stages, then adding memantine as the disease progresses. But each patient should be assessed for side effects, nausea, vomiting, dizziness. Those are big side effects of these medications, and we want to get the lowest dose possible. Lastly, we want to remember that these medications aren't going to do it on their own. We want to use medications in conjunction with other non-pharmacological interventions to promote wellness and prevent cognitive decline. So what are these non-pharmacologic interventions? There's a bunch of them. Aromatherapy has been shown to reduce agitation and depression. Music therapy also has been shown to reduce anxiety and depression and improve quality of life. There's also new studies on bright light therapy, which we also use for seasonal affective disorder, which promotes sleep and adjusts our circadian rhythm. So it treats more of the side effects of the dementia. Safety concerns are always going to be a priority of a patient with dementia, and all of our patients really, but environmental modifications are vital interventions for people with dementia because these factors profoundly affect safety, functioning, and quality of life. General environmental modifications include compensating for our sensory deficits, so having floor surfaces that are low glare, that are not slippery, that are not cluttered, having good lighting, adequate lighting, using clocks, calendars, and other pieces to reorient the patient or a family member to time and place, Other things we want to do is use cues or simple written instructions. So sometimes even on a remote, you might get rid of all of the extra buttons and just have a few arrows and an on and off to help them function in their own home without getting so frustrated. We can put familiar pictures around the house. And then another big safety piece is identification of the patient, making sure they're carrying identification at all times, or enrolling them in programs such as Safe Return, which is sponsored by the Alzheimer's Association, so that if a patient does have wandering behavior or they get lost in a big group, that they have that ID and we can find a reliable family member with a family member's phone number as soon as possible. Keeping the environment, again, safe from clutter or other poisonous chemicals, like keeping cleaners away, putting medications in a lockbox or somewhere where they're not going to overdose on them. Routines, keeping routines simple and consistent, and consistent as possible to maximize their independence. And some techniques here in the book they talk about are leaving clothes out for the next day, or leaving out hygiene items in the correct order, like leaving out a toothbrush, a hairbrush, glasses in the same spot to give them those visual reminders that they need to do this and then do this next. Lastly, there's dementia-friendly communities that have really started in the UK and are gaining a lot of ground over there. But it's a community that's a city or a town that's been identified as having a highly community education on dementia, understanding dementia and respecting and supporting patients with dementia. So in these dementia-friendly communities, people will be aware of and understand the disease so that the people can live in the way they want. So access to transportation, making sure that activities include people with dementia with them, businesses that respond, that are informed of how to deal with behaviors and questions of people with dementia. So pretty cool idea on getting big communities involved. Lastly, people with advanced dementia will have severely limited judgment and insight. Cognitive decline greatly accelerates also in people with dementia when they have an underlying acute medical condition or when they're hospitalized. And this can lead to serious complications, which increases the risk of mortality. For this reason, families should address advanced directives and financial planning early on in the diagnosis, because it is a progressive disease and estates should be managed. Now we're going to go on to some sample test questions. A patient in a long-term care facility is starting to have difficulty reasoning, having abstract thoughts, and learning new things. This patient is showing symptoms of a declining function of what? So getting my highlighter back out here. So difficulty reasoning, abstract thoughts, learning new things. So learning new things, we're going to cross this one out, right? Well, maybe this should be red, right? It's not really a long-term memory thing, right? Because long-term memory is essential for storage and retrieval of information, as well as it's not really a short-term memory thing, because this is short-term memory has to do with a holding tank for really recent and immediate events. So you might think it's that one right away, but let's think more into what kind of actual cognitive functionality they're having. So we need to know what crystallized intelligence and fluid intelligence is. So crystallized intelligence refers to vocabulary, information, and verbal comprehension that people acquire through life experiences, whereas fluid intelligence is the skills of integration, indicative reasoning, abstract thinking, flexible and adaptive thinking. So it's going to be fluid intelligence. This is learned from over time with experience, but fluid intelligence is what we need to take an idea and learn from it. Which statement is true related to mandatory reporting laws? So mandatory reporting laws do not require reporters to know whether abuse has occurred. Mandatory reporting laws do not require reporters. Oh gosh, I'm sorry. So looking at these answers here, can we delegate? No, not really. You can collaborate, but you can't delegate. We do not have to report suspected cases. Absolutely not. That's not what mandatory reporting means. Mandatory reporting laws do not provide immunity. No, there are bylaws to keep the reporter safe, like a whistleblower effect. And so A is the true statement here. You do not have to have proof and evidence that the abuse has occurred, but if you suspect it, you have to report it. And so mandatory reporting laws merely want us to report and suspect its occurrence. The responsibility for problem verification rests with the public agency charged with law implementation. So, your judicial and your law enforcement agencies. It does not lie with us as the referral source. Dementia with Lewy bodies is characterized by what? Remissions and exacerbations over many years, memory impairment, muscle jerks, and blindness, Parkinsonism symptoms, including muscle rigidity, or increased intracranial pressure secondary to decreased, that should probably say CSF drainage there. So dementia of Lewy bodies, think of what is that, and what kind of dementia is this, right? So we have the 4 types of dementia: the vascular, dementia with Lewy bodies, frontotemporal dementia, and Alzheimer's dementia. And so this really is not really a characteristic. It's too generalized. That could be anything. That could be heart failure. That could be diabetes, remissions and exacerbations. That could be MS. That's a lot of different things. So it's not a true characteristic of Lewy body dementia. So really we're kind of thinking it's between 2 and 3, because 4 is going to be more of an organic cause, which is a secondary reason for having cognitive changes. So memory impairment, muscle jerks, blindness. But if we remember when we talked about Lewy body dementia, it's very similar to the Parkinsonism syndromes. So we're going to have more muscle rigidity, the mask, and the slow gaits with the dementia of Lewy bodies. DB recently lost his car downtown and had to take a cab home. He is unable to recognize his surroundings. He is unshaven with oversized slacks and a worn shirt. What possible problems do the symptoms suggest? Well, lost his car downtown, so that's kind of a warning sign. Unable to recognize his surroundings, unshaven, worn shirt. What possible problems could this be? Well, of course, we're probably thinking dementia, right? That he is having progressive memory loss here. What else fits? Depression, right? This oversized slacks, a worn shirt. Patients, older patients, even if they have underlying dementia, they're more prone to showing cognitive impairment and depression, anxiety, and other mental health disease states. So this could be depression, this could be dementia. This isn't Parkinson's disease. I mean, this would be very late, you could argue that one, but we're not going to go that far. It also could be maybe signs of alcohol abuse, Wernicke's encephalopathy, inability to care for yourself, but it's definitely not E. So it is not normal to have these symptoms as above. DB was diagnosed with vascular dementia. 4 months later, you see DB in the clinic with his daughter, who has been providing 24-hour home care. DB is fairly stable, but the daughter is anxious, irritable, and confides that she is very stressed by the need to provide constant supervision. What's the best response by the nurse? So we have many responses here. So what we're tasked in this question for is what's the most therapeutic way to discuss with this daughter, her concerns. So this one's the shortest, so we'll go with this one. You're doing great, keep it up. We're not validating any of her concerns. So we don't want to pick this one, right? We're just kind of blowing her off with this statement here. You should look into skilled nursing facilities that provide memory care to reduce your stress. We could talk about skilled nursing, but is this the most therapeutic way to bring it up, right? I understand you're feeling overwhelmed at times. Some options for respite care include caregivers in the home or daycare programs. There, we're again addressing her feelings. We're validating what she's saying. I understand what you're feeling. And then we're giving some solutions here. That one sounds really good to me. And then there's C, your brothers should move your father into their home so that he can have more male companionship. This is kind of more of a judge, like a judgy answer. And it's also taking it away that, maybe saying, well, you obviously can't do this anymore. Let's find something else. So the best option here would be B, our therapeutic response. Which of the following is an age-related physiological change that may affect the absorption of drugs? And so when we're looking at age-related changes, the things we see here, so dry mouth, that's usually related to, that's not an age-related change, that's usually related to medications here, right? Faster stomach emptying. Is that true? No. Look at B and D. They're basically saying the same thing, but we actually have delayed stomach emptying and we have decreased GI motility. So even if we didn't know that the pH was altered in the stomach contents, we know A, B, and D are definitely not true. So our answer here would be C. Pharmacokinetic processes altered in aging include absorption, first pass metabolism, bioavailability, distribution, protein binding, and renal hepatic clearance. Age-related physiological factors that may affect the absorption of drugs include delayed emptying time of the stomach, altered pH of the stomach contents, and slowed GI motility. Changes in these processes begin with alterations in the functioning of individual cells. Okay. Which enzyme is the most important factor in the first phase of drug metabolism? So this goes back to talking about the Beers criteria and the START table for identifying drugs that are appropriate for the older individual. And older individuals are usually have polypharmacy, so they're prescribed 5 or more drugs for multiple chronic conditions. And most of these drugs are going to be metabolized through the liver. So a functioning liver plays a significant role in our metabolism of drugs, and it's the major site of drug transformation and elimination. And drugs administered by the oral route must pass through the liver prior to reaching systemic circulation. So the enzyme in the liver is this CYP450 enzyme here. So D would be the correct answer. It's the most important factor in the first phase of drug metabolism, and it is expressed in the liver. The use of multiple medications has been associated with decreased adherence due to what? Cost, burnout, complexity of regimens, or all of that. Usually in test-taking strategy, it's usually always all of the above. And it is, right? Older adults often have multiple conditions, the treatment of which might call for several medications. So this polypharmacy can quickly escalate to be a burden on patients or their caregivers. The use of multiple meds has been associated with decreased adherence due to the high cost of the medications, the complexity of following the appropriate regimen, and burnout from taking so many medications and staying on it. So if possible, steps should be taken to limit the number of medications. And if a single medication may be of benefit for more than one of a patient's conditions, it should be preferred over multiple agents. Also, selecting the appropriate meds for geriatric patients is more complicated by the lack of clinical guidelines and completed research focusing on this population. So using, again, the START criteria and the Beers criteria to help us decide on those meds is a safe alternative to polypharmacy. Which of the following factors in older patients with diabetes may lead to hypoglycemia unawareness? So again, we're talking about normal physiological changes of aging. So more rapid intestinal absorption of calories. So what did we talk about before? We didn't talk, it was slower GI motility, right? So it's not this one, right? Heightened adrenergic response to low blood glucose. So what do we think of that one? Well, I don't really like it. So as a patient ages, the adrenergic response to low blood glucose diminishes or disappears. So this B is incorrect because it should be decreased adrenergic response. So we have decreased tachycardia. Misdiagnosed or unrecognized early symptoms of hypoglycemia or lack of patient education on the signs and symptoms of hypoglycemia. So the question is asking, what factors, and most likely, if we're looking at physiological changes of aging, we're going to look at misdiagnosed or unrecognized. Age-related changes include drug absorption, distribution, metabolism, and clearance should all be considered. And for frail patients, those risks of glycemic control can outweigh the benefits. So, excuse me, the preliminary symptoms of hypoglycemia, including like shakiness, lack of motor skills, and confusion, are often unrecognized or misdiagnosed in the older adult, and this can result in the hypoglycemia unawareness, that they're not recognizing that a confusion, so a caregiver isn't recognizing the confusion, or the person isn't recognizing their shaking hand as hypoglycemia before it gets too late. A 70-year-old patient has not been taking his medications for hypertension and coronary artery disease. The nurse discovers the patient's son, who has control of the finances, has not been purchasing the medications, and the patient's bank account only has a few dollars available. This is an example of what? So we have different forms of abuse labeled here. So what kind of abuse is this 70-year-old patient at risk for or going through? And so this would be C. This one is financial exploitation or material exploitation, because we have, the medications. We identify medication non-adherence, and when we're looking at more into it, we're looking at finances and the patient's bank account. And so financial exploitation or financial abuse happens when money or belongings are stolen from an older adult. This can include forging checks, taking someone else's social security benefits, or using a person's credit cards and bank accounts without their permission. It also includes changing names on a will, on bank accounts, insurance policies, or titles to homes and cars without permission. Last question, which of these is not an example of possible elder abuse? A, although a patient complains of pain, the caregiver rarely provides pain meds prescribed as needed to the patient. B, the family member responsible providing care leaves a bedbound patient unattended all day. C, a patient with severe dementia is left alone for long periods of time without supervision. And D, an adult child refuses to bring a grandchild to visit their grandparent, even though said grandparent is begging for a visit. So looking at all of these, all of them are A, B, and C are all forms of neglect. In A, the nurse is showing maleficence, and we know that non-maleficence is what our aim is in nursing care, and she's not attending to primary needs. So this would be nursing neglect in A. B is also caregiver neglect, not meeting the primary needs of the patient, and C would be neglect as well, that the patient is a patient with dementia has safety risks and safety needs, which we've discussed in the case study previously. And so a known patient with dementia without supervision could be seen as neglect. Where D, there's a lot of missing context here, and it's not abuse to refuse visitation for personal reasons. Right, I hope this helped. Thank you so much.